Hi, I'm Chris Lieu. I'm a GI medical oncologist at the University of Colorado Cancer Center. So when should patients with incidental appendiceal net found on a routine appendectomy proceed to right hemicolectomy? And this is something that comes up in multidisciplinary tumor boards. It comes up actually when patients just show up to medical oncology clinics where they're told that they have a cancer and they're not really sure what to do. So to give some background, appendiceal cancers can comprise several different histologic types, right, including mucinous neoplasms, neuroendocrine tumors, and adenocarcinomas as well. The presentations of these cancers are oftentimes variable, but a lot of times adenocarcinomas or nets of the appendix are often found after just getting a routine appendectomy for what is presumed to be appendicitis, and they're found incidentally when the pathology returns. And so patients are often completely asymptomatic when a diagnosis is established, so they honestly feel fine. But for the purposes of this discussion, we're going to be talking specifically about appendiceal neuroendocrine tumors as opposed to appendiceal adenocarcinomas. And a lot of times when we talk about these appendiceal nets, we talk about them as well-differentiated tumors. And it's really important to understand that appendiceal nets versus appendiceal adenocarcinomas are staged and oftentimes treated very, very differently. So to kind of give a background behind this, it's really important to review the AJCC staging for appendiceal neuroendocrine tumors, as that differs actually significantly from adenocarcinomas. So when you talk about a well-differentiated net, the T stage differs from colorectal cancer staging. So in colorectal cancer staging, the T staging is really based on the depth of invasion of the cancer. But for appendiceal nets, the T staging actually takes into account the size of the tumor. So for example, a tumor that is less than or equal to 2 centimeters in largest diameter is considered to be a T1 tumor. If a tumor is between 2 and 4 centimeters, it's a T2 tumor. And if the tumor is greater than 4 centimeters or has subserosal invasion, it's a T3 tumor. Kind of like colorectal cancer, T4 tumors perforate the peritoneum or directly invade into other adjacent organs or structures. So it's extremely important to keep this T staging in mind, because I will tell you, this is sometimes inaccurately reported on pathology reports. And the most common mistake that I see is that appendiceal nets are staged like colorectal cancer, whereas what we just talked about obviously involves size, which is oftentimes obviously not part of colorectal cancer adenocarcinoma staging. So this is the information that we also use to proceed or not proceed with a right hemicolectomy. So it's really, really important to get this correct. A key question that comes up often in these patients is when to proceed to a right hemicolectomy when an incidental net is found. And though the guidelines vary a little bit from organization to organization, the easiest way to remember this criteria is that if the tumor is found to be greater than 2 centimeters in greatest dimension, the team should strongly consider a right hemicolectomy due to the risk of tumor spread and lymph node involvement. If the tumor is less than 2 centimeters, oftentimes a right hemicolectomy is not recommended. A right hemicolectomy should also be considered for patients if their surgical resection is either incomplete or if the margins of the resection are positive. NCCN guidelines currently recommend a CT or MRI imaging of the abdomen and pelvis, and you can consider a dotatate gallium-68 scan to assess for any lymph node or metastatic disease for any tumors that are greater than 2 centimeters. These tests should also be considered if the resection is incomplete or if the margins are positive, because it can at least give you a sense for the extent of disease. Regarding surveillance, if an incidental appendiceal net is less than 2 centimeters, no surveillance is indicated. You're pretty much done, right? If tumors are greater than 2 centimeters, surveillance is recommended every 12 to 24 months for a total of 10 years, which is a very, very long time. And so some kind of like a real life issue is that given the radiation risks, this is one scenario where I actually do consider MRI surveillance given the long duration of surveillance currently recommended by the NCCN guidelines. And finally, for completely resected, well-differentiated appendiceal nets, adjuvant therapy is usually not recommended. This is because chemotherapy has traditionally been ineffective in treating these tumors. And no studies have really shown any benefit of adjuvant therapy with octreotide or lanreotide following complete resection. So therefore, in your patients that do undergo right hemicolectomy, surveillance would really be recommended without any need for adjuvant systemic therapy.